Hello everyone, my name is Dr. Sikandar and today we will discuss about pneumothorax. So let's get started. So what is the definition of pneumothorax? So yeah, we can tell like pneumothorax is defined as air in the pleural space that is between the lungs and the chest wall. So the term pneumothorax was first coined by Itard in 1803 and in 1819 Laennec described the clinical picture of pneumothorax, like what symptoms and signs are there in the pneumothorax patient. So like this condition is already defined since 200 years. Yeah. So what is the etiology of pneumothorax? So according to the etiology, pneumothorax can be classified into grossly spontaneous pneumothorax and traumatic pneumothorax. So spontaneous pneumothorax further can be divided into primary and secondary pneumothorax. Primary pneumothorax is like because of any unknown cause, and like secondary pneumothorax is because of underlying lung disease. And then comes traumatic pneumothorax. It could be iatrogenic or non-iatrogenic. Like iatrogenic means like we have induced it. So because of interventional procedures like central venous catheters, or like we when used to aspirate from the we used to aspirate the pleural fluid, and it could be due to positive pressure ventilation also. And like in non-nitrogenic, it could be due to penetrating trauma, or like a gunshot wound, or like any incise incise wound, or it could be due to blunt trauma, like due to rib fracture or any other blunt trauma. So yeah, now we will discuss about the primary spontaneous pneumothorax. So it occurs in young healthy individuals. Very very important. It used to occur in young healthy individuals without underlying lung disease. So there is no underlying lung disease. It is due to rupture of apical subpleural valve. Very very important. It is due to rupture of apical subpleural valve. And what are the predisposing factors? So smoking, tall, thin males. These are the predisposing factors for primary spontaneous pneumothorax. Then comes recurrence, like what is the recurrence of primary spontaneous pneumothorax? So they are telling like in the same side it occurs reoccur in 50% of the cases, and like in 10% cases its recurrence is like 10%. Then they are telling about the like what is subpleural valve. So this is the pocket of air within the visceral pleura. So like we can see this is the lung, and on the lung there is visceral pleura, and in visceral pleura there are like these valves are there, like pocket of air are there. And here also we can see like these are the subpleural valves inside the this like visceral pleura. And in the CT scan we can see like nearby the lung, attached to the lung and the visceral pleura, there are like pocket of air are there. And these are usually less than 1 centimeter in size, and usually apical in the location. Very very important. Then comes secondary spontaneous pneumothorax. It is due to underlying lung disease, like it could be due to obstructive lung disease, like COPD, asthma. Then it could be because of interstitial lung disease, like idiopathic pulmonary fibrosis, or UIP, or NSIP, eosinophilic granuloma, histiocytosis X. So it could be due to these interstitial lung diseases, or it could be due to pulmonary infection like pulmonary tuberculosis, pulmonary pneumonia, or it could be due to lung malignancy like primary lung carcinoma or pulmonary mets. Then like it could be due to connective tissue disorders, very important, because of rheumatoid arthritis, very important, ankylosing spondylitis, or Marfan syndrome, or scleroderma. Or in other, it could be due to pulmonary infarction, pulmonary hemorrhage, pulmonary alveolar proteinosis, or tuberous sclerosis. Then they are talking about the traumatic pneumothorax. So traumatic pneumothorax can be occurred due to accidental trauma, like blunt trauma with fracture of ribs, or it could be due to penetrating trauma by stab wound or gunshot injury. It could be due to iatrogenic trauma, like positive pressure ventilation. So how like positive pressure ventilation causes pneumothorax? So they are telling like alveolar rupture will produce interstitial emphysema, and this emphysema can like further rupture and can create pneumothorax. Then they are talking about the interventional procedures like biopsy, thoracocentesis, CVP line. In these, all those things like needle can prick, and like it can create it can go till the like it can rupture the visceral pleura and create the opening between like lungs and the pleural space. So it can create pneumothorax. Then they are talking according to the pathology, like pneumothorax can be divided into three parts: closed pneumothorax, open pneumothorax, or tension pneumothorax. So what is the closed pneumothorax? So they are telling like in closed pneumothorax, air will be in the pleural space, and there will be connection between the lungs and pleural space. and pleural space will not be connected with outside environment. But in open pneumothorax, like this pleural space will be directly connected to the external environment. So like this kind of connection will be there. And in tension pneumothorax, very very important, there will be connection between environment and the pleural space, and this will be connected with one-way valve. Like air can enter the pleural space, but it can't go outside. So continuously air will come inside this pleural space and it will collapse the lung. It is an emergency condition actually, very important. So again, they are talking about these like closed pneumothorax. The pleural tier is sealed and the pleural cavity pressure is less than the atmospheric pressure. Very important. So yeah, this point is very very important. So like pleural cavity pressure is less than the atmospheric pressure. Then they are talking about the open pneumothorax. The pleural tier is open and the pleural pressure is equals to the atmospheric pressure. Very very important. And in the tension pneumothorax, the pleural tier act as ball and valve mechanism, and the pleural cavity pressure is more than atmospheric pressure. Very very important. So yeah, according to these things, we can divide them. Next comes what are the clinical features of pneumothorax. Very important. So like we will discuss one by one. So they are telling like about the symptoms and physical signs. First, we will discuss about the symptoms. So chest pain is the most common mode of presentation, usually acute onset and localized to the side of pneumothorax and exacerbated by deep inspiration and postural change. And there will be dyspnea and other clinical features, underlying lung disease related features will be there. So they are telling like dyspnea is more common in secondary spontaneous pneumothorax rather than primary spontaneous pneumothorax due to poor pulmonary reserve. Suppose there is a patient of emphysema, so like because of poor pulmonary reserve and like patient is having pneumothorax, then like patient will suffer and like there will be dyspnea will be like more common in those patients. And in ECG, sometimes left-sided pneumothorax, very important. This is very important point. So they are telling like sometimes left-sided pneumothorax can show ECG changes like transmural myocardial infarction, but these changes resolve after re-expansion of lungs. Very important. So like left-sided pneumothorax can mimic transmural MI. Then comes physical signs. So they are telling like small pneumothorax may be impossible to detect in the physical examination. So there is no importance of physical signs in small pneumothorax. And they are telling like moderate to large pneumothorax, if it is present, then on examination of chest reveal that the side with pneumothorax is larger than contralateral side, with moving less during respiratory cycle. Okay, and then they are telling like tactile fermitus will be absent and the percussion note is hyper resonant and the breath sound will be absent or reduced on the affected side. Very, very important. Then they are talking like about the tension pneumothorax. Tension pneumothorax should be suspect if patient has tachycardia, like pulse rate or heart rate is more than 140 and tachypnea and cyanosis and hypotension is there. Then they are talking about the radiological manifestations. So what are the radiological manifestations? So let's start. So they are telling like if we will do chest X-ray in erect position, then air will be in apicolateral space. Very important. So it will be in apical and lateral space. So here like this will be the position of air in chest X-ray of like erect position. If patient is lying in supine position, so air will come in anteromedial pleural space. Very important, like this. So like air will come like this in anteromedial pleural space. Very important. So we should remember this. Is like if X-ray is of erect position, then air will be in apicolateral pleural space. And if patient is in supine position, then it will be in anteromedial pleural space. Very important. Then they are talking about the like, yeah, again they are talking about the pneumothorax in erect X-ray or supine X-ray. So in erect X-ray, like it could be a small pneumothorax, or it could be large pneumothorax, or it could be tension pneumothorax. If it is a small pneumothorax, then visceral pleural line will be there and apical lucency will be there. If it is large pneumothorax, then apical lucency will be more than 2 centimeter in width. Very, very important. Means apical lucency will be more than 2 centimeter in the width, and visceral pleural line will be there. Then they are talking about the tension pneumothorax. And tension pneumothorax lung will be collapse, very important. Mediastinal shift will be there, and low flat diaphragm will be there, very, very important. And then they are talking about the supine X-ray. In supine X-ray, there will be deep costophrenic sulcus sign, very, very important. So we used to like discuss these things in our day-to-day clinical practice. Like in supine position, deep costophrenic sulcus is very, very important sign. So then they are talking about the lucent cardiophrenic sulcus will be there, sharp mediastinal contour will be there, and double diaphragm sign could be there. So we will discuss them one by one later. So yeah, what is like a small pneumothorax? So in this picture we can easily see like this is the vessel pleural line and this is the pneumothorax. So this is a small pneumothorax because like this width is like less than 2 centimeters, so this will be a small pneumothorax and vessel pleural line is present. In this picture we can easily see the visceral pleural line. Then this is the large pneumothorax. I think you can like easily identify this is the visceral pleural line and this is the pneumothorax in the left side. So in this picture we can see this large pneumothorax is having more than 2 centimeter in size. Like the width of this pneumothorax is more than 2 centimeters. So this is the large pneumothorax. And this is the large pneumothorax with mediastinal shift. So we can see this is the right-sided pneumothorax, which is very large, and it is like shifting this mediastinum. So yeah, we can see like lung is still there, like more than this is the spinous process of vertebra, and it is reaching till there, and like this left lung is shifting to left more. So again, we can see this is the lucency, and this right lung is shifted toward the left. So this is the mediastinal shift in this large pneumothorax, or this could be tensor pneumothorax. So yeah, they are talking about this is another picture of left-sided tensor pneumothorax, and we can see there is like mediastinal shift to the right, and this is the collapsed lung. This is the small collapsed lung, and this is the depressed hemidiaphragm. Depressed left hemidiaphragm is there. So again, we can see what is the visceral pleural line. So this is the visceral pleural line, which can easily be seen, and this is the lung. This is the like pleural space, and yeah, very very important. So there is no vascular marking after this visceral pleural line. Very very important. So yeah, after that they are talking about the what is the differential diagnosis of visceral pleural line. So there are so many other things can confuse us with this visceral pleural line. So yeah, it could be skin fold, very very important. It could be skin fold. So they are telling like positive mass band, optical edge enhancement, and it extend beyond the chest wall. If like this thing is extending beyond the chest wall, then it is due to skin fold, very very important. And lung marking can extend beyond this thing. Like if lung marking is present beyond this line, then it is due to, it is like skin fold most probably. Then they are talking about the, it could be due to scapular edge. So this medial border of scapula could be there. So we should not like confuse with this scapular edge. It is not vessel pleural line. Then they are talking about the, it could be emphysematous bulla. But like how we will differentiate it with emphysematous bulla? So they are telling like emphysematous bulla will be rounded, while pneumothorax is concentric and tapered toward the lung base. So it will taper toward the lung base, but this emphysematous bulla will not taper toward the lung base. And double wall sign on CT is consistent with ruptured bulla causing pneumothorax. Very very important. If this bulla is ruptured and it is causing pneumothorax, then there could be double wall sign in the CT. Very very important. So yeah, we can see here like this is the giant emphysematous bulla. This is not like we have already discussed. Like pneumothorax usually they used to be in apical and lateral side. Very very important. This is not in apical lateral. This is like apicomedial side. Very very important. And this is not like tapering, but and like this is very rounded shape. And in CT we can confirm this like easily. This is like uh, this is the septa, and like this is bounded with septa. So this is a emphysematous bulla. This is not a pneumothorax. Again, we can see these are emphysematous bulla, and so these all are emphysematous bulla, small, small, and like these, this is the small portion of pneumothorax, very important in the periphery. So yeah, again we can see this is the pneumothorax part, the apical in the apical portion, and again in this this small part is also pneumothorax in left side. But like other all these lucent part are these are like because of emphysematous bulla. So what are the sign of pneumothorax in supine position? Let's start. So there will be deep costophrenic sulcus will be there in supine position. Very, very important. So this is the deep costophrenic sulcus is there. This is deep costophrenic sulcus. So this is because of pneumothorax in the supine X-ray. And there will be sharp mediastinal contour will be there. So again, we can see this is the sharp mediastinal contour. It is because of this pneumothorax only. So again, like we can see what is the double diaphragm sign. So this double diaphragm is seen in pneumothorax only because of subpulmonic pneumothorax. Very very important. So this double diaphragm sign is seen in subpulmonic pneumothorax. Then again we can see this is the lucent cardiophrenic sulcus. Very very important. This is the cardiophrenic sulcus, and which is lucent. What are the ultrasonographic sign of pneumothorax? So there will be loss of lung sliding will be there. There will be loss of comet tail, loss of seesaw sign. Like in M mode, there will be loss of seesaw sign, and stratosphere or barcode sign will be present. Very very important. So if stratosphere sign or barcode sign is there, then we will say like it is because of pneumothorax. In normal condition, seesaw sign used to be there, and in pneumothorax, seesaw sign will not be there. And these lung sliding and comet tail appearance, which is normally present, it is absent in the pneumothorax. Very, very important. So yeah, what are the complication of pneumothorax? So they are telling like recurrence of spontaneous pneumothorax could be there. There could be tension pneumothorax. There could be hydropneumothorax. There could be encysted pneumothorax. Failure of expansion of collapsed lung could be there. They are telling pneumothorax could be there. Pneumothorax could be there, or respiratory failure. Finally, it could be there. Then they are talking about the recurrence rate of spontaneous pneumothorax. So, like we have already discussed, like it is 50% on the same side and 15% on the contralateral side. And it is more common in secondary spontaneous pneumothorax, which are due to underlying lung disease. Very, very important. So now we will discuss about the tension pneumothorax. Like it is life-threatening condition. So tension pneumothorax is a life-threatening condition. The pleural pressure is more than the atmospheric pressure. Very, very important. So radiological manifestation of large pneumothorax will be there, like mediastinal shift will be there, flattening of hemidiaphragm, and lung collapse will be there. It will be associated with clinical manifestation of circulatory collapse like tachycardia, hypotension, and sweating. It is more common with positive pressure ventilation and traumatic pneumothorax. Then they are talking about this is like a chest X-ray of tension pneumothorax. This is right-sided pneumothorax, and this is small right lung which is collapsed. Very, very important. This is the picture of hydropneumothorax. It is due to rupture of pleural adhesions and bronchopleural fistula. There will be like this kind of picture. So we can see like this is the right-sided hydropneumothorax. This is the left-sided hydropneumothorax. Very, very important. Then again in this picture we can see this is the encysted pneumothorax. Due to pleural adhesion, there will be like a small uh, it will be like they are in a small part of pleural space, and it will be like it will not extend beyond adhesions, and like it will be limited by pleural adhesions. Then comes what is failure of re-expansion of collapsed lung. So it is due to either due to pleural adhesions or due to tracheobronchial injury. It will failure to re-expand the collapsed lung. Then like in this picture we can see like re-expansion pulmonary edema could be there. So they are telling like it is due to rapid re-expansion of collapsed lung. So if we will put ICTD, this is the we can see right-sided pneumothorax, tension pneumothorax, and we will put this ICTD, and it will cause this re-expansion pulmonary edema. Very, very important. So yeah, because of rapid expansion of collapsed lung, it can create re-expansion pulmonary edema. Very important. So yeah, guys, they are again they are talking about the what is the like how we will quantify the pneumothorax, like what is the size, what is the like exactly we can define it, like the severity or like yeah, grading of pneumothorax is there. So there are like five guidelines are there. Like first is light index, then Collins method, then Riaz method, then BTS guideline, and ACCP guidelines. So yeah, let's start. So this is the lights index. So how we will define the percent pneumothorax? So they are telling 100 will be outside, and then 1 minus diameter of lung ka cube divided by diameter of hemithorax cube. So this small collapsed part is lung. Here we can see this is the collapsed lung till here, and this complete part is till the chest wall is hemithorax. So hemithorax will come below, and this diameter of lung this will come upward, and we will take the cube of them, and then we will like minus it from 1 and multiply it with the 100. So the volume of lung and the hemithorax are roughly proportional to the cube of their diameter. Therefore, one can estimate the degree of collapse by measuring an average diameter of lung and the hemithorax and cubing these diameter and finding the ratio. Then comes Collins method, very important. So like Collins have described an alternate method for estimating the percentage of the collapse, the distance between the apex of partially collapsed lung and apex of thoracic cavity. So yeah, at apex we will take distance A, then at the midpoint of upper and lower half we will take like distance B, and lower half we will take distance C. Of the collapsed lung and the lateral chest wall were measured in the centimeters, like that. Again, we can see in this diagram. So they found that the percentage pneumothorax size could be calculated by this formula. So at apex, we will take this A distance, and this is the distance between parietal and visceral pleura only, like between the chest wall and the lung only. So at apex, we will take point A, and at upper half, we will take point B, and at lower half, we will take, at the mid of lower half, we will take point C. So yeah, we will like take a constant 4.2 plus 4.7 into A, B, C. So this is like very simple formula. So suppose like, yeah, we can like check for a patient. Suppose like A point is 2, B point is it is 1, or C point is 1. So like how we will take, so it will be like 4.2 plus 4.7 into 4. Then we will multiply it, and it is like around 18 plus 4, around like it will be around 22. So it is like that only. So yeah, guys, it will be like 22%. So we can define like this is 22%. So let's move ahead. So what is the Riaz method? Riaz method is like a third method for estimating the size of pneumothorax. The Riaz method use a nomogram that relate the average intrapleural distance to the pneumothorax size. So on this nomogram, there is a 10% pneumothorax for every centimeter. So yeah, according to them, suppose like that, suppose this is the pneumothorax size. So like suppose this distance is like around around 2.5 centimeter. So we will take like maximum distance between parietal and visceral fluid. If this distance is 2.5%, then we will directly multiply it with 10. Then it will be around 25%. So this is like very simple way to like calculate the percent of pneumothorax. Then comes BTS guideline. So what is the BTS guideline? So BTS guideline say like if the distance is less than 2 centimeter, then this is a small pneumothorax. And if the distance is more than 2 centimeter, then this is the large pneumothorax. And what is the ACCP guideline? So according to them, like a small pneumothorax is less than 3 centimeter, large pneumothorax is more than 3 centimeter. Very simple. So like how we will manage a patient with pneumothorax? So like first thing is observation, then observation with oxygen inhalation, then aspiration, or tube thoracostomy we can do, or tube thoracostomy with installation of sclerosant agent, or video assisted thoracoscopic surgery we can do, or open thoracotomy can be done. So these like there are multiple ways to manage the pneumothorax. So first thing is observation. Like when we will apply observation, observation is the treatment of choice in small closed and primary spontaneous pneumothorax which occupy less than 15% of hemithorax without significant breathlessness. Very, very important. So according to like Light's guideline, so we should mark it if it is less than 15%. If we have like measured it and it is less than 15% of pneumothorax, hemithorax, and it is without significant breathlessness, like clinical features are not there, then according to Lights, this is a small and closed pneumothorax, and it should be small and closed pneumothorax, and so we should like observe this patient only. Like we do not need any intervention. Then rate of resolution of spontaneous pneumothorax is 1.25% of the total percent of pneumothorax in every 24 hours, which is a slow process. Very, very important. So in every 25 hours, like rate of resolution is 1.25% of spontaneous pneumothorax. Very, very important. Then the addition of high flow oxygen therapy has been shown to result in fourfold increase in the rate of pneumothorax resorption. Very important. If we will give a patient high flow oxygen, then it can increase, like resorption can increase 4 times. Very, very important. So yeah, we should give oxygen supplementation to a patient with uh, primary spontaneous pneumothorax. He is on observation. Then comes aspiration. So what is like simple aspiration? Simple aspiration is recommended as the first line treatment for all primary pneumothorax requiring intervention occupying greater than 15% of the volume of hemithorax. If it is primary like pneumothorax, then we can do simple aspiration. Simple aspiration is less, and this occupy more than 15% of area. Simple aspiration is less likely to succeed in secondary pneumothorax. So it is not beneficial in secondary pneumothorax, it is beneficial in primary pneumothorax only. And in this situation, is only recommended as an initial treatment in small pneumothorax in a minimally breathless patient under age of 50 years. So they are telling like if in secondary pneumothorax patients come and like pneumothorax is very small and patient is minimal breathless and age is less than 50 years, then we can apply simple aspiration in case of secondary pneumothorax. Otherwise, there is no role of simple aspiration in secondary pneumothorax. Patient with secondary pneumothorax treated successfully with simple aspiration should be admitted to the hospital, and that person should be observed for at least 24 hours before discharge. Very, very important. So we should observe that patient for 24 hours if patient is having like secondary pneumothorax. Then comes simple aspiration, like air is manually withdrawn until no more can be aspirated. If no resistance has been felt after aspirating a total of 4 liters, it is assumed that no expansion has occurred and a tube thoracostomy is performed. Very, very important. If we have aspirated 4 liters of air through this simple aspiration, and like it is not like there is no resistance is felt, then we should put a tube. If no air aspirated and resistance is felt, chest X-ray should be done after 4 hours of observation. If adequate expansion persists, patient can be discharged. Very, very important. Like we should observe that patient for 4 hours, and then we should perform a chest X-ray, and then we can discharge that patient. Very important. Patient should be returned in like 1 to 3 days for follow-up with chest radiograph after a simple aspiration. They are telling like repeated aspiration is reasonable for primary pneumothorax when first aspiration has been unsuccessful and patient is still symptomatic and a volume of less than 2.5 liter has been aspirated on the first attempt. Then we can repeat aspiration. Like on the first visit, like we have tried only less than 2.5 liter aspiration and patient is symptomatic, then we can try for a primary pneumothorax this simple aspiration. They are telling like catheter aspiration of pneumothorax can be used where equipment and experience is available. Catheter aspiration kit with the integral one-way valve system may reduce the need of repeated aspiration. So we can put a catheter and like it will reduce the obviously like repeated need of like repeat aspiration. Then they are talking about the intercostal drainage tube, which is known as tube thoracostomy. Very, very important. So it could be guide wire tube thoracostomy or trocar tube thoracostomy or operative tube thoracostomy or single port thoracoscopic tube thoracostomy. So what is like intercostal tube drainage? If simple aspiration or catheter aspiration drainage of any pneumothorax is unsuccessful in controlling the symptoms, then an intercostal drainage tube is inserted. Intercostal tube drainage is recommended in secondary pneumothorax except in patients who are not breathless and have very small pneumothorax. Otherwise, in all patients with secondary pneumothorax, we used to perform this intercostal tube drainage. Then they are talking like with tube thoracostomy, air in the pleural space can be rapidly evacuated and chest tube should be positioned in the uppermost part of the pleural space. Then intercostal tube drainage, like what should be the size of chest tube when the patient with pneumothorax are treated with tube thoracostomy? A small tube like 10 to 14 French should be used initially because their insertion is much less traumatic than the than that of the larger tubes. So like we should put small tubes. If lung does not re-expand with small tubes, then a larger tube of like 20 to 24 French can be inserted. However, it appears that most of the patient can be successfully managed with small chest tubes only. Like how we will do suction, it is the recommended that no suction be applied to the chest tube inserted for spontaneous pneumothorax. Okay, so like we should not do suction for like spontaneous pneumothorax because the risk of re-expansion pulmonary edema is greater when suction is applied to the chest tube. Suction is not recommended. Very, very important. We should not do suction. However, if lung does not expand after 2 days of water seal drainage suction, then suction should be applied to the chest tube. Like we can apply after 2 days if this lung is not expanding. Then they are talking about the intercostal tube drainage, high volume, low pressure intercostal tube drainage is there, like minus 10 to minus 20 centimeter of water it should be there. Suction system are recommended. Okay, so like suction of 10 to 20 centimeter of H2O, which is high volume low pressure suction, it is applied. Then they are talking about the tube clamping. There is controversy as to whether the chest tube should be clamped if lung has re-expanded and if there is no air leak, then either we should like clamp the tube or not. So this is a controversy actually, according to this light. Then they are talking about the if a chest tube for pneumothorax is clamped, this should be under the supervision of respiratory physician. If a patient with clamped drain become breathless or develops spontaneous emphysema, the drain must be immediately unclamped. So yeah, if patient develop spontaneous emphysema, then it should be unclaimed on the spot. Or patient become breathlessness. Very, very important. Chest tube should remain in the place for 24 hours after the lung re-expand and the air leak ceases. A chest X-ray should perform if lung expansion has occurred, then chest tube should be removed. Very, very important. They are talking about the what are the complication of ICTD. So perforation of major organ can be there, pleural infection can be there, or surgical emphysema can be there. And like what is the recurrence? Approximately 50% of the patient with primary spontaneous pneumothorax have a recurrence whether they are treated with observation or tube thoracostomy. Like it doesn't matter. It will reoccur in the 50% of the cases. Then they are talking about the tube thoracostomy with pleurodesis. It is defined as instillation of sclerosing agent into the pleural space through the chest tube in an attempt to create an intense inflammatory reaction that would obliterate the pleural space, leading to pleural symphysis. Sclerosing agent like quinacrine or tox slurry or olive oil or tetracycline derivative like doxycycline, minocycline, and 10% povidone iodine can be used. Then they are talking about like what are the sclerosing agent for fluoridasis again. So like talc can be used. What is the advantage of talc? Like it is cheap and easily available and it has highest efficacy. But the disadvantage are like it can cause ARDS and renal failure. Very, very important. Then what about the bleomycin? Bleomycin has efficacy similar to talc, but it is very costly and chest pain, fever, nausea can be there. What about the povidone iodine? It is cheap and easily available, but it can cause anaphylaxis and randomized study required involving large number of patients. Like there are not that much studies are available. And what about the tetracycline or doxycycline? It is very easy available, and like but disadvantage it like it is very painful and it can cause acute respiratory failure. Then what about the surgical management? Video assisted thoracoscopic surgery with bleb or bullectomy can be done. Video assisted thoracoscopic surgery with partial or total pleurectomy can be done. Open thoracotomy can be done. Transaxillary mini thoracotomy can be done. Video assisted thoracoscopic surgery, the entire lung can be inspected and a search for cause of air leak can be carried out. VATS is performed surgical. VATS is the preferred surgical procedure for young fit people with complicated or recurrent primary pneumothorax. It is less reliable in case of secondary pneumothorax. So VATS is good in the young and fit people with complicated or recurrent primary pneumothorax. In case of secondary pneumothorax, open thoracotomy and repair is still the recommended approach. Very, very important. If a patient is with secondary pneumothorax, like there is underlying lung disease is there, then open thoracotomy and repair is a recommended approach. Very important. VATS offer significant advantage over open thoracostomy. Like it is a shorter hospital stay, significantly less post-operative pain will be there, and better pulmonary gas exchange in the post-operative period will be there. And recurrence rate is 5 to 10% only. However, VATS cannot be considered superior to open thoracotomy. Very, very important. Like open thoracotomy is always better than VATS. It can't replace open thoracotomy. So what about the open thoracotomy? Like what are the indications? So secondary ipsilateral pneumothorax or first, like it is second ipsilateral pneumothorax, or it is like first contralateral pneumothorax, or bilateral spontaneous pneumothorax is there, or persistent air leak or failure to completely re-expand, or pneumothorax with professions at risk, like in pilots or drivers is there, then we will perform the open thoracotomy. It is according to BTS guideline 2010. So what are the indications? It is second ipsilateral pneumothorax or first contralateral pneumothorax or bilateral spontaneous pneumothorax or persistent air leak or failure to completely re-expand, or pneumothorax with profession at risk like pilots or divers. So in open thoracotomy, like it provides lowest post-operative recurrence result, and bulla ligation, excision can be done. Thoracotomy with pleural abrasions and either apical or total pleurectomy all have failure rate under 5%. Like it is not more than 5%. Morbidity from thoracotomy from for pneumothorax has overall incidence of 3.7%. Then open thoracotomy may be associated with increased post-operative respiratory dysfunction in hospital stay compared with VATS procedure. However, it is suggested that the success rate with open thoracotomy procedures are higher. Very, very important. It is higher than VATS. Thus, surgical authorities suggest open thoracotomy procedures in patients with secondary pneumothorax who may have extensive pleural disease requiring more extensive pleurectomy and subpleural bullectomy. So in those cases, we will do open thoracotomy. What about the transaxillary mini thoracotomy? So it is minimally invasive procedure and recurrence rate is 0.4%. Complication rate is 10%. These results make this procedure a reasonable alternative to open thoracotomy. So yeah, we can perform this also. So yeah, now we will see like management of spontaneous pneumothorax according to British Thoracic Society BTS guidelines. Let's start. So like if a patient with spontaneous pneumothorax comes to you, and like it is if it is bilateral and hemodynamically unstable, and like proceed and which lead to chest drain, like spontaneous pneumothorax if bilateral or hemodynamically unstable, which proceed to chest pain comes to you, then you have to see if age is more than 50%, significant smoking history there or not, evidence of underlying lung disease on the chest x-ray is there or not. If all of these things are there, means it is yes, then it is due to secondary pneumothorax. If these things are not there, then this is primary pneumothorax. So if it is like primary pneumothorax, then we should see the size of pneumothorax. If size is more than 2 centimeter and patient is breathless, if these things are there, then we should like aspirate with 18 to like 16 to 18 gauge cannula, and we should aspirate less than 2.5 liter. If it is like after that this is successful and like less than 2 centimeter and breathing is improved, these things occurred, then like, or like size is size is not more than 2 centimeter, patient is not breathlessness, if this thing is there, then like we should consider discharge, and we will tell the patient to review after within 2 to 4 weeks. If all these things are not there and like this is not improving, then we will go in this flow chart. And like these things are present, then it is because of secondary pneumothorax. If it is because of secondary pneumothorax, then we should see the size and breathlessness. If these things are also there, then finally we will go to chest drain, and like it should be 18 to 14 French and admit the patient. So we should put ICTD if this things is like second pneumothorax is there, like patient is having more than 2 centimeter size pneumothorax and breathless is there, patient is breathless. If these things are not there, then like we should see the size. If size is less than like it is 1 to 2 centimeter, then again we should consider like for aspiration with 16 to 18 gauge cannula, and we should aspirate less than 2.5 liter. After that it got successful, then it's okay. If it is not getting successful, then we should do ICTD. If it is getting successful, or it is like only 1 to 2 centimeter size, then we should like give him give like admit the patient and give him high flow oxygen unless suspected oxygen sensitive patient is not oxygen sensitive, and like we should observe the patient for like around 24 hours. So this is the flow chart of this a patient with spontaneous pneumothorax, very important. Then what about the tensor pneumothorax? In case of tensor pneumothorax, patient should be given high concentration oxygen. A cannula should be introduced into the pleural space, and usually in a second anterior inter- intercostal space in mid clavicular line we should insert it. Ear should be removed until the patient no longer compromised. Then an inter ICTD should be inserted in the pleural space. Then what about the iatrogenic pneumothorax? The treatment of iatrogenic pneumothorax tend to be simple as there is less likelihood of recurrence, and majority will resolve with observation alone. If required, treatment should be by simple aspiration. We should not do ICTD in patient with iatrogenic pneumothorax in most of the cases. What about the catamenial pneumothorax? Catamenial pneumothorax occurs in conjunction with menstruation. It is an interesting kind of pneumothorax. It used to occur in conjunction with menstruation, and it is usually recurrent. Patients with catamenial pneumothorax classically develop chest pain and sometimes dyspnea within 24 to 48 hours of the onset of menstrual flow. And catamenial pneumothorax may be more likely if the patient's menstrual period is preceded by mental or physical stress. These pneumothorax are usually right-sided, and but left-sided and even bilateral pneumothorax can be reported. It occurs due to transperitoneal migration of endometrial tissue through the small defect in the right hemidiaphragm into the pleural space. And treatment of catamenial pneumothorax is aimed an attempt to treat the endometriosis. If patient is having endometriosis, then we should treat the endometriosis, and it will automatically treat the catamenial pneumothorax. What about the hemothorax? It is like presence of blood in the pleural space. Mortality rate is 20%. Source of blood is chest wall, side of vascularized adhesions. So what is the treatment? Treatment is aspiration or tube thoracostomy or blood transfusion and thoracoscopy or thoracotomy. And what is re-expansion pulmonary edema? It is an unusual but well-documented complication of spontaneous pneumothorax, which may follow the re-expansion of a completely collapsed lung. Okay. And like incidence is 0.9%. Common symptoms are cough, dyspnea. Unusual symptoms are marked respiratory distress and hypotension can be there. And treatment is cough suppressant. We should give him cough suppressant, oxygen therapy, and steroid therapy. We will give in these patients with re-expansion pulmonary edema. Then comes like respiratory failure. Respiratory failure is common manifestation associated with spontaneous pneumothorax, more commonly associated with secondary spontaneous pneumothorax. And what are the features of respiratory failure? Like dyspnea, hypoxia, hypercapnia, respiratory acidosis will be there. And what is the treatment? Treatment is urgent chest tube insertion we should do, and controlled oxygen therapy according to arterial oxygen therapy. Bronchopleural or alveolar pleural fistula. So BPF is communication between the bronchus and the pleural space. Where is the communication between the pulmonary parenchyma distal to the segmental bronchus and the pleural space is known as alveolar pleural fistula. So when we will call it alveolar pleural fistula, when it will be like distal to segmental bronchus and pleural space in between these things. So what are the types of air leak? So there are four types of air leak, very, very important. First is continuous air leak. Like it will be there in inspiration, it will be there in expiration, and in between it will be there. So it is known as continuous air leak. If it is present in inspiration only, then we will call it like inspiratory air leak. Second number. Third number is expiratory air leak. And it could be in force expiration also. So it will be force expiratory. So as air leak begin to resolve or heal, they usually go from E to FE leak. Very, very important. So yeah, like from C to FE, like initially it will be continuous, then inspirated, then expirated, then force expirated. Very, very important. Then what about the what are the take home messages? So patient discharged without intervention should avoid air travel until a chest radiograph has confirmed resolution of pneumothorax. Very, very important. Okay, so like there should be like confirm resolution of pneumothorax in chest radiograph. After that only we can tell patient to like go for air travel. Diving should be permanently avoided after a pneumothorax unless the patient has bilateral surgical pleurectomy. Otherwise, diving will be completely permanently avoided. Primary pneumothorax patient treated successfully by simple aspiration should be observed to ensure clinical stability before discharge. After aspiration, simple aspiration, we should observe the patient. Then breathless patient should not be left without intervention. Very important, regardless of the size of pneumothorax on the chest. If clinically patient is like breathless, then we should not see the size of pneumothorax. We should do some intervention. Very, very important. Secondly, pneumothorax patient who are successfully treated with simple aspiration should be admitted for 24 hours before discharge to ensure no recurrence is there. So that's it for about the pneumothorax. Thank you so much, guys.